Welcome everyone to today's AHRQ Fall and Pressure Ulcer Prevention Learning Network webinar. We've joined them this month and we have a special guest speaker who will be talking about strategies for sustaining change. And this is a particularly relevant topic for all of you as you've now spent more than a year crafting, implementing, and fine-tuning your fall and pressure ulcer prevention interventions as part of this AHRQ initiative. Now, although we have a few people that are still logging on, we're going to go ahead and get started on time so that we don't lose any valuable time for our later question and discussion. So this shows the agenda for today's webinar. We're going to quickly walk through some housekeeping items, and then we're also going to review our upcoming webinar schedule, and then we're going to dive into our feature presentation, which is being led by Posa. A few housekeeping items. We've reserved a little bit of time, 10 to 15 minutes at the end of this presentation for questions and discussion, and we hope you'll participate in that discussion. Feel free to submit questions that you have for Pat using the chat panel throughout this presentation. And please make sure if you do use the chat panel or the Q&A panel that you direct it to all participants and panelists, just to all participants. Now, everyone is currently on mute until we reach the question and discussion section, and at that time we will unmute the lines. And if you'd like to ask a question during that time, please raise your hand using the hand tool, or you can simply chime in if other people are not speaking. Also note that at that time, please do try to keep background noise to a minimum. Turn down the volume on your computer if you haven't already done so, especially if you've joined by the telephone, so that there's none of that interference noise that we often hear. And also, please make sure that you not put your line on hold at that point in time, because we will be able to hear any hold music that you have. So this slide just shows the webinars that we have coming up for both the fall and the pressure ulcer prevention learning networks. For our fall prevention hospital cohort, we're going to be hearing from Kate Walsh in November, and she's going to be talking about teaching critical thinking skills for fall risk assessment. And then in December, we have another guest speaker, Susan Mascioli, who will be talking about her institution's Lean Six Sigma process for reducing falls. For our pressure ulcer prevention hospital cohort, in November, we will be hearing from Karen Zolkowski on the topic of pressure ulcer prevention measurement and using data to tell a story. And we are still at this time developing the schedule for the upcoming webinars in the first part of the next year. Now I'd like to actually welcome our guest presenter today, Pat Posa. Pat is Assistant Performance Improvement Leader at St. Joseph Mercy Health System. She's held various roles in her healthcare in her 31-plus years of practice, including serving as a critical care staff nurse, a manager, an educator, and a director of nursing, and administrator of an outpatient multi-specialty primary care clinic. In her role is to oversee quality and patient safety in critical care areas for 4 hospitals and implementation of a program to manage severe sepsis and septic shock throughout each of the hospitals. And in 2015, Pat was named a Michigan Health and Hospital Association Keystone Center Senior Fellow. And in that capacity, she supported the planning and development of interventions to improve patient safety and the quality of care delivered in Michigan hospitals. Excellence in clinical practice is her passion, and she has been involved in many programs that aim to achieve that. Pat also published many articles in both clinical and quality journals. She lectures extensively, both nationally, on various critical care and quality topics. And today we're pleased to have her join us to talk about issues related to sustainment. So at this time, I'm going to pass it over to you, Pat.
Great. Well, thank you for having me, Michelle. I'm really excited to be with you guys today and talking about sustainability, which is often the element in the room, and how do we get this to continue to work. So what is sustainment? It's about holding gains and evolving as required, so you're not staying stagnant, but definitely not going back to the old way. The next 30 plus minutes, and we're going to leave lots of time for questions, I'm going to talk about some key elements of sustainability, the components of sustainable change, and some of the common barriers and how to address them. So we begin to worry about sustaining the gains. I know you guys have been involved in this project for a while, but thinking about sustainability needs to happen throughout the project, right? And if you followed the that's been provided in the format, you have put in some key components of sustainable change. You don't want to just focus on sustainability at the very end of the project, the last month, because that's often too late to make any changes so they can maximize the potential. So think about it in terms of baking a cake. You have all these ingredients and you put them in just so, and you time it correctly, cook it correctly, but you don't worry about sustainability throughout until the end, is going to be too late to make any change. So it's important to ensure that you've done all the things from the beginning in order to achieve the best outcomes. And you had a pretty extensive journey so far. And from your toolkit, your journey included assessing readiness, managing change, implementing practices, reviewing those best practices and then implementing them, measuring, and used a lot of tools throughout the whole process. And then now you're moving on to sustainability. So all of these steps in your journey are all components to good sustainable change. By sustaining change. Change needs to be so integrated into your organizational work, into your processes and routines, and no longer thought of as separate. This is just how we do it here. And so that is key. This can't be considered, oh, it's the flavor of the month and we're going to work on falls, and once the AHRQ group is done, then we'll go back to business as usual. That's not sustaining change. And so we're going to talk about the top 10 components to ensure that you have sustainability in the change and program that you've implemented over the course of the last year. We're striving to become high reliability organizations. And so what does that mean? It means that we provide consistent performance at high levels of safety over a long period of time. And that's very hard to achieve. Three main components of high reliable organizations is that they possess a collective mindfulness, understanding that even small failures in safety protocols, deviations from processes can lead to catastrophic or adverse events if they don't take action to solve the problem. So they have an overzealous look and worry about failure at all, in everything that they do. The second key component is that they eliminate deficiencies in their processes through powerful process improvement tools. And so you've been educated on a lot of those as well. And then the third, and one of the key factors, is creating an organizational culture that focuses on safety, constantly aware of the possibility of failure. And as Michelle talked about in my introduction, I've been part of the HA Keystone ICU project since it began with AHRQ funding and Dr. Pronovost from Hopkins. And that was the key difference, is really putting in, worrying about safety culture and changing your culture to ensure that it will support will support change. Common leadership mistakes is to expect technical solutions to solve adaptive problems. So I'm clinical. My background is a critical care nurse. There's lots of evidence-based practices that we put into place every day. But and those are technical solutions to solve. If I want to improve the outcome of someone who's on a ventilator, I need to do certain things. Without changing the culture and worrying about the adaptive components of change, I'm not going to create sustainable change. So understanding that there's technical work that needs to be done. So in this group, your technical work has been all of the fall and pressure ulcer prevention strategies you've put in place. You've you put in place risk assessments using validated instruments. You've created tailored care plans based on that risk, not just generalized across everyone, but tailored based on that risk, and then consistently carrying out those specific individualized care plans based on that patient's risk. So the technical work lends itself to reminders and use checklists and standardizing processes and protocols, and that's all important. But if you don't combine it with the adaptive piece, and adaptive work is work that shapes the values, attitudes, and beliefs and values of a clinician so that they consistently perform tasks the way they should. So, for example, in the critical care environment, we had certain beliefs. It was part of our culture that our patients would get pneumonia on the ventilator and they would get central line bloodstream infections, that they're just really sick and things happen. Until we began work on our culture and changed people's attitudes and beliefs that these events are preventable and that we need to work to prevent them, we're not going to be successful in putting in these interventions because people are going to say, well, why should I do this? It's inevitable that this will happen. And so this adaptive work, a lot of what you guys did in your sections related to managing change, improving the safety culture on the unit are key because to have that along with the technical interventions in order to have sustainable change. So here are 10 strategies to ensure that you have sustainable change. And we'll walk through each of these, and after that we'll talk about common barriers. First strategy is to engage leaders. I know this was part of your journey. Why you need to engage leaders? Because your leadership is not supportive of what you are doing and feels the value and can structure and hold people accountable, you're not going to get this to continue long term. So how do you engage leaders? Well, you have to let them answer the question, what's in it for me? Why should I worry about this? Why is this important? And one of the best ways to do that is through patient stories of harm. Also, they're looking at, what drives them besides just general good care, right, and the best for our patients is scorecards, both financial and clinical, quality scorecards. And so talking to them in their language and sharing how important these outcomes are is significant. So cost avoidance, estimation, patient throughput, turnover reduction, overall decrease in patient harm. So leaders need to be aligned to the improvement efforts. And I know in our prevention of harm in our facilities and through the state of Michigan, you had an executive sponsor for each of those key programs. And that executive sponsor or senior leader really is critical to bring down barriers, helping problem solve, and then holding accountable the team to getting the outcomes that they set forth to achieve. Engaging leaders in the hospital in general, where senior executives walk around on the unit and talk to frontline staff, is another key strategy to sustain change. So leadership support is usually vice president or higher. Sometimes in large organizations, they even have director level to ensure that each unit gets someone pay attention to them, and they're rounding on the unit. And these executives might not be clinical, so you need to help prepare them to be comfortable and support that as they're rounding. But it's really talking to frontline staff, because frontline staff know what's safe and what's not safe and where their concerns are, because they work in these processes every day, and some of the processes might be broken. Some examples of what happens on rounds are as staff, how the next patient might be harmed in the unit, what barriers do you have that are in place that prevent you from providing the best care for patients, how's your teamwork, all of the things that are important to a positive safety culture. And I know in our organization we have, and I'll show you an example, but we have learning boards or huddle boards where we display current metrics. These are out in the hallway, patients, families, whatever can see them. And we huddle each shift, have a safety huddle talking about what's working, what's not, where are our goals for the unit, and getting input from the staff. And so engaging your leaders when they're rounding at the learning board is a great strategy. So key leaders need to be engaged. Having an executive sponsor for your falls and pressure ulcer program is vitally important. They can support it and make sure that it's part of report cards, et cetera, holding people accountable, but also breaking down barriers and then engaging with frontline staff so the executive sponsor of a falls group might, when they're rounding on the units, they might be asking questions specific to what's working with falls. When was the last time someone fell, and what did you guys find was the cause? And what are the barriers from you making this work in your unit? The next three items I've grouped together, it's really about having a multidisciplinary group that you've put together to do this work continue on. Having local physician champions, and then making sure that you have frontline staff involved so you can tap into their wisdom. Your falls or pressure ulcer prevention groups that have done this change over the last year, what are your plans to keep that going? So some things that can be merged into an existing group, or this group continues to meet. If you haven't been able to impact a significant amount of your falls and reach the outcomes, then that group might need to continue to meet. Otherwise, you might be able to merge it into another group, an existing group. So maybe in your organization, you have a group that looks at hospital-acquired injury, and you could combine falls and pressure ulcer into that group. So that's, you want to have a place for this team or for this work to be continued, because it doesn't end. You have to continue to refine and measure how things are going and tweak, and new literature comes out, et cetera. So part of the sustainability plan is what's going to happen to this group as the project winds down. Continue or merge to an existing group, make sure work of this group, if you continue as a separate fall or pressure ulcer prevention group, you have to make sure that you're linked within your quality structure in your group, that your quality store is asking for outcomes or reports. At our organization, we have a quality and safety committee that's made up of director level and above, and the key priorities in the hospital have to present their work. What have they achieved over the last year? What are their goals for the next year? And what issues and barriers that the executives might be able to assist in breaking down. So the other important piece that as you transition from the falls or pressure ulcer prevention group is within a group, or as it merges with an existing group, you need to continue to have clearly defined goals and action plans going forward. And that's not something that ends. Yes, you created your implementation plans when you worked this past year, but that needs to continue, because as you measure, you're going to find issues and barriers. Maybe some of the prevention strategies haven't stuck yet, and so you're going to have to begin to tweak things to understand why they didn't stick and begin to tweak it so it can stick. New literature might come out on different strategies. You'll want to be able to continue to improve so then that your team continues to read goals and develop action plans. And again, its goals should be aligned with the organizational goals of preventing harm, be part of the dashboard. I know we report skins and falls. It's on our dashboard, and so it's in front of everybody. It's talked about at our executive huddle every day. That's a way to keep it going. As either an merged group or the individual group, again, should include local champions, at a minimum a nurse and physician that can continue to carry this work on, and find staff. Maybe they're not able to attend every meeting, but need to have the ability to tap into their wisdom. And as we're continuing to meet, executives and leadership need to support people attending meetings, collecting data, and other activities as well. And this is often where people stall and fall off, is we're in a budget crunch, all the meetings get canceled, or I have some short staffing issues on a unit and I can't send someone, or I didn't budget for people attending meetings and they should be paid for it. And so as you move into continue budget next year, make sure that you're budgeting to be able to engage frontline staff and support them attending meetings. If you support them, they're going to see that, okay, this is valuable. They're allowing me to move my workplace to be a part of this group. So it sends the right message, and that's often one of the barriers that people face is it's not supported that these meetings occur by leadership and that I'm reimbursed for them or I'm given the time to be able to attend to them. So the fifth is to learn from your defects or learn from your errors. So when you have a fall and a pressure ulcer, why did it happen? And this, remember in talking about high reliable organizations, one of the key components of that is creating a positive culture of safety. And that is recognizing the inevitability of errors and proactively seeking to identify latent threats and then resolve them. We learn a lot more from our errors than from our successes. Beto tells us, give me a fruitful air anytime full of seeds bursting with its own corrections, and you can keep your sterile truth to yourself. So you get a lot of valuable information when you study your failures. You pick up hidden causes, trends, and you'll be able to identify how to reduce the risk. So it's important to learn from your failures. And so post-fall or post-pressure ulcer, you should be performing as a routine either a root cause analysis, or we used a shortened tool similar to a root cause analysis, but this came out of Johns Hopkins, and it's called Learn from a Defect. And it's very similar to the root cause analysis, and the root cause analysis in your toolkit is very robust and specific for both falls and pressure ulcers. You're really answering the questions, what happened, why did it happen, and you're not looking at what people did something wrong, but what went wrong in our process. And to identify what that root cause is or the issue that you believe led to the fall, what are you going to do to reduce the risk of it recurring? I know, so we do post-fall and post-huddles, and in the post-fall huddle, we'll do right there after the patient falls, because we want to make sure that we prevent them from falling on the next shift. And so it's important to do it in a timely fashion, and using the Learning from a Defect tool has allowed us to do that. And we script it similar to what you see in the root cause analysis. You're looking to see was the risk assessment done appropriately and timely, and were the appropriate interventions put in place and carried out that based on that patient's risk. So a lot to learn from that, and then you need to take information back to your team and say, okay, these were the last pressure ulcers, or these were the last falls, root cause analysis on them. Okay, trend this, let's look to see what's wrong and where we have opportunities in our process. Combining this along with your data and other process data that you should be collecting ongoing will give you a good way to decide where you need to focus efforts next. Okay, since 7. As you're putting in these new processes, right? You've implemented new tools maybe you weren't using, some specific risk identification tools. Maybe there were certain prevention strategies based on that risk that you hadn't been doing before. And so you want to ensure that it happens with every patient every time based on their risk, and so that can occur through standardization. And then how do you ensure that it's focused on each day? So how do you include it into that patient's daily goals? How do you make it visible to all the members of the team that this person might be at risk, and talk about it every day? So here are just some tools that help you to integrate the prevention practices into the usual care of patients. So if you do interdisciplinary rounds throughout your hospital, multidisciplinary, where you have docs versus maybe case managers, maybe in a area where you have a lot of wounds and issues, your wound care specialist might be on those rounds. Are those rounds scripted to where each of the people participating in the rounds will review certain things? I gave you an example here on the right side of the screen. This is in our ICU. This is the rounding script that the nurses use when as they're part of interdisciplinary rounds, and it includes key interventions that we want to ensure each of our ICU patients have. And so you can see on the second page, we look at skin, we look at the different lines, and have as many falls in ICU, so it's not called out on that script, but skin, we look identify if that patient's at risk and do we have all the right things in place, and based on that patient's risk level. It's important to have those independent redundancies so that you can ensure that those practices are integrated into just everything you do. Purpose hourly rounding. If you're rounding on your high-risk patients, and you should have certain things that you're looking for on those rounds. And if this is a fall risk, you would want to assess, based on their risk level, do they have all the right interventions in place. Leader roundings. We have managers on each of the units round on the patients at least once during their stay, if not daily, and they are looking for these practices being in place. So another check. Huddles below on the left-hand side of the screen is an example of a huddle board where we have certain clinical metrics, quality metrics at the top where we talk about them every day, and those change based on whether or not we achieve them. And then the staff can give input on the bottom right is where the staff can get input on why we didn't meet a metric or where some of their barriers are. Different types of checklists, including this in your handoff, are all ways to ensure that these new practices get forced and integrated in the usual care of patients. So checklists aren't the end-all be-all. If you don't have a positive safety culture, then having a checklist that if I don't do something on the checklist, I can't tell anybody about it, no one will respond to it, then your checklist isn't going to help you. So you have to combine it with having that positive safety culture where people feel comfortable speaking up, they're encouraged to speak up, and the team communicates well with each other. But checklists are important because and I don't remember the quote, but nursing staff does so many tasks in an 8-hour shift that it's easy to forget certain things. So stress and fatigue can compromise our cognitive function, and so making checklists are important. And it doesn't mean that you're not knowledgeable, that you're not an expert practitioner. If we learn from our colleagues in other fields such as aviation and aeronautics, they use checklists. It doesn't matter if you were a pilot and you've flown, have 10,000 hours, you're completing the same checklist because we understand human factors and how the brain works, and it's hard to remember long lists of things, and so checklists are very helpful. 8 and 9 in the top 10 strategies are talking about what are you going to measure, how are you going to track your prevention practices, and then what are you going to do with the data, both your outcome data, so what your pressure ulcer rate is, as well as what your fall rate is, but then those process measures. How often are you assessing fall risk appropriately? How often, based on that risk, if a specific intervention should be implemented based on that patient's risk, is it being done? It's important to set up a regularly scheduled process metric data collection process. You should be collecting outcome data, and that's important, but it's really that process data. So you put in this change, you're doing a new prevention practice, you have to see if it's been done. It's great to look if a fall happened or a pressure ulcer that, oh, we didn't do these 3 things as you do your root cause analysis or you're learning from that defect. But you want to know up front, in broad brush, if we have this new practice to be done when this risk level is identified, you got to go out and look to see if it's being done. So along with collecting process data, looking at your outcome data and the information from your defects, that's where you're going to identify where your opportunities are to continue to hardwire practice. And that data is key. The data will help your team identify next steps, where the issues are, but you need to share that data along with your improvement team. It needs to be shared with the frontline staff and help them understand it and you talk to them on why. If you're not getting the processes done the way you think should be done, the frontline staff is going to help you determine why. Then leadership, it's important to keep them in the loop and on progress as well as barriers. Remember, the leaders are there to help us break those barriers that we might be facing. Another thing is to continue to train new staff in the evidence-based practices. So you've put all this work in, you've changed new processes. How are you going to make sure when you onboard new clinicians, both nurses, nursing assistants, physicians, to these new practices? So you got to incorporate it into orientation for all disciplines. And remember, even if you're on the right track, you'll get run over if you just sit there. So the change that you made, you need to continue to look at it and continue to see what other changes might be necessary. As your patient population might change, the evidence comes out and shares some additional things. So you can't just sit there. So common barriers to sustainability. These are competing priorities, buy-in, changes to patient engagement, difficulty implementing changes consistently, and resistance to spread. You want to anticipate these barriers, and your team should begin to talk about them if you haven't already. So there's always going to be competing priorities. People, the whole world stops when you update your electronic medical record, right? But you need to not have it happen or recognize, but have some things in place to continue working on, maybe if you have a big thing that's happening in the organization that's going to take people's time, realize that, but understand that we have these 5 things that need to continue. How do we make them continue? And this is where having leadership support is so important because they're going to be able to allocate people time and help people identify and break down some of those competing barriers. One of the questions people ask is, how long do I collect the data and what type of data do I collect? And so if you look at improvement science and you talk about it, your sustainment period is your control period in the world of Six Sigma. And so you have to have some key metrics, process and outcome metrics that you watch on a regular basis. And if they move out of control, you have set some triggers up to be able to say, okay, we need to take a deeper dive in. If you are consistently assessing your processes and you have great compliance with them, you can decrease the frequency of collecting that data. And so instead of collecting it monthly, maybe you go to every other month, and if it continues to have been hardwired and you're getting great outcomes and the process metrics are showing 95, 98% compliance, then you can move to quarterly. But you take your eye completely off the ball, that's when drift happens and the gains that you have made can often so pick metrics, both process and outcome, and continue to collect that data. Step buy-in and engagement. If you followed the process that has been outlined in this program, where you have identified your key stakeholders, you've engaged leaders, you have frontline staff involved in this work, there are people that will assist you in getting the buy-in. And by bringing data to the staff and having them help problem solve, that's also listening to them. That's also going to help with buy-in. oftentimes you might have open units, travelers, rotating staff, lots of turnover, and it's there to ensure that they have adequate training. And that's tough, but you need to, just like you're incorporating this into your orientation and onboarding processes, you know you have a lot of other staff coming in, it floats into the unit. You need to find a way to either match them up with a staff person on that unit to go over key practices, or make sure that they do some training prior to coming. It's really about changing the attitude that this is not a project, this is just how we will care for patients and how we ensure that we can prevent harm. And it's really having that frontline staff participating and working on that adaptive piece of change, the cultural change that is going to be the greatest, gain the greatest success in your staff buy-in engagement. We involve patient families in all the work that we do. And there's challenges to patient engagement. And I thought I had, okay. So oftentimes families don't know what the role is when their loved one is in the hospital, and the patients don't know what their role is. They don't speak in a different language in the hospital, and so they're confused. Maybe they've had bad experiences in the past with another loved one or even themselves, and so they have a mistrust. Those are often the issues when related to patient engagement. And how do you resolve those? Well, it's about inviting them in, and a lot of organizations around the country have patient and family advisory councils, and every meeting, so maybe on your fall and pressure ulcer meeting, you put in a family member that had a fall or a patient that had a fall, because it can give you a perspective that you're not going to gain from anyone else. If there's good communications amongst patients, have you invited patients and families into your interdisciplinary rounds? What is the communication between the healthcare team and the family? Do you use other tools like whiteboards in the room that has the names of the caregivers as well as what the plan is for the day, and a place maybe for patients and families to write questions? So there's lots of strategies to help engage families, and especially throughout the whole process, as well as during the discharge phase. We out on other strategies to engage patients and families. And we're running out of time, so we won't today. An area is, how do I get this done consistently? And usually that's a result of competing by priorities. You haven't got staff to buy in to that this way is the right way, and so have you not, do you not have champions in place? Because from their co-worker would be helpful. Physician hearing it from a physician, co-worker, nurse hearing it from a nurse. Have they not seen it? Do they not know the evidence? Have not gone back and shown that in the experience of other hospitals as well as in the hospital, when we've put this in place, we see better outcomes. So the frontline staff, this is all part of that staff buy-in engagement. If they're involved in the process, understand the process, everyone can't be involved in everything, but you have those champions, and then you bring this information out to the unit and have discussions there, you're going to get the staff to support it. Change consistently is also about hardwiring it, changing that culture from we just do this because this is the project of the month, or this is just how we do it here. And put in those independent redundancies, the checklists, incorporating this into handoffs between staff, as well as into interdisciplinary rounds, are all important ways to ensure that the change gets implemented consistently. Your EMR is often can be your friend, or it can delay things significantly, and this is where your executive can help. If you have a specific change that you need to put in your EMR and it's critical to you guys achieving the outcome that you want to achieve, then that's where your executive is there to help you. If not, you might have to do something, an interim step before it gets placed into the EMR. Other things that your ability to change consistently is insufficient education and training, and not believing this is the best practice. And so we've talked about strategies to help with that. A lot of times you want to spread, if you've targeted one specific unit for the work, you want to spread it to other units, and you can meet resistance when trying to spread that change. And it's really about the key components to any change is, have you involved the key stakeholders? When you're going to another unit, even though it's the same unit in the same it's a different unit in the same hospital, their culture might be different. Their patient population might be different. Some of their processes might be a little different. So you can't necessarily slap something on that worked in one unit and have it completely work in another area. So in the midst of taking a progressive mobility program that we have done in our ICU for a number of years and spreading it hospital-wide, in order to spread that change, we're not going to say, okay, you guys do the stuff that we've done in the ICU. We're going to, again, look at the literature. We're going to adapt the tools that had in the ICU, but use the frontline staff and the leadership in the non-ICU areas to adapt the program to meet the different patient needs and the different processes that you might have. So these are the top 10 strategies for fall and pressure ulcer prevention, sustainment. And so you can take these to your team and kind of use this as a checklist. Do we have all of these components in place? And part of your sustainment plan would be, okay, if we don't, how are we going to do that? And the barriers I discussed are barriers in your facility, and if so, what are some of the things I can do to overcome those barriers? Lots of references, and we have about 10 minutes for questions.
Thank you so much, Pat. That was a really nice presentation. I'd like to open it up. Deidre, you can go ahead and take folks off mute so that we can have some questions. I see a hand up. Barb, go ahead.
Thank you, Pat. That was perfect. Wonderful, especially the examples and the how you took what you did and you applied to our particular projects. So I'm one of the QI specialists working with 5 of the hospitals on fall prevention. And one of the things you mentioned in the beginning was collective mindfulness. And that's one of the things we are seeing as a success in any of the hospitals, the increase in awareness by the staff. So I know that you keep it up through education and making sure the new staff are oriented to it. But could you address, and you did sometime in this, but I'd like you to reinforce how folks that we're working with, the contact, can keep that awareness up, keep that collective mindfulness going. That's my question.
So, Barb, great question, and it's really about how are you integrating it into your practices. So we put, and so some of this is the structure that you have within your organization. so we have, and like many other organizations, have standardized interdisciplinary rounds through the hospital. And so collect mindfulness in the scripts in those rounds about preventing harm. And so it gets brought up there. We have safety huddles throughout every shift. Every unit does a safety huddle. And falls, and you can see here on the left-hand side at the bottom, it was 7 days from the last skin injury. And so that's where the collective mindfulness comes. These aren't just sheets of paper in your office, Barb. These are things that hit the frontline staff. Your frontline staff knows when the last fall was, should know when the last skin injury is and why and what are we going to do different. So it's some of those structures that you need to put in place will help reinforce and help you achieve that collective mindfulness. And
one follow-up question, because we've talked about these, and I love the way it brings together. When you were talking about the leader rounds, you mentioned that the huddles occur once a shift. Do the leaders attend those huddles every shift? And what level of leadership?
So we have youth-based huddles that occur each shift, and we have an executive hospital safety huddle, and anyone can attend that. And that's at the same time every day, 10:45. And then each unit has defined their time that works best in their process. And the unit managers attend the huddles, and directors and above will attend on regular basis. You know, if it's once a month, or the executive team that owns that unit or does safety rounds at unit, so they'll the huddles once a month when they're doing safety rounds.
That's great. Thank you.
You're welcome.
So other questions or comments for Pat? And feel free to raise your hand or chime in. So while we're waiting for some of our participants to maybe think about a question that they'd like to ask, I'm wondering if what your thoughts are on Pat, on whether or not we rely too much on champions with all the staff turnover. I mean, are there any strategies for sort of dealing with that? If we're relying on champions to help communicate, and then they leave, and then the effort may potentially fall apart. So I'm just wondering your thoughts on the role of champions and how much to rely on champions.
Well, I think champions are important because it's one from the physician and the nurse champions are key to these. So you have someone in a like discipline being able to get it from their perspective and then talk to people in that discipline. Just anything else, you need a succession plan for champions. So if you know someone is going to leave, then you have to assign another or get a champion. In our improvement work that we do in our ICU, that same team has met, since 2003, but two people on the team that are the same members. And the champions have changed throughout the years. I truly do believe champions are important. Need to ensure that champion understands the evidence and understands what their role is in reinforcing and assessing and talking with staff. And then it's good to change out champions. or may have more than one champion related to a specific issue. So I don't believe they should go away. I do believe they add a great service, and your sustainability and your staff buy-in, they're one of the key stakeholders, and they are carrying that flag every day.
Great.
I have a quick question. This is Dave McMillan from Broward Health North. Also started in the ICU and rolled out to the rest of the units, and as we were rolling out to the rest of the units for our HAPUs, just the different ratios and, like you said, different cultures and things presented tremendous roadblocks for us as we were working through that. We have rolled out house-wide now, but one thing that I asked, our specialist is, we had to change a lot of our standards and things that we expected from as we got less further away from acute care, because acute care 2-to-1 ratio, by the time we got down to the med surg and rehab, we were at 8-to-1, 9-to-1 sometimes on the ratios. So we had to change expectations. Is that something that you guys also found as you're rolling out?
So absolutely, and that's where you have to look at the processes. Now, some of the expectations you don't change, right? So
correct.
The expectation that a risk assessment is done every shift, that's standard throughout.
Mm-hmm.
But you are going to have to tweak some of the things. I'd be cautious that you don't move away from the evidence, because the evidence is evidence on preventing ulcers and falls, but you're going to, again, might not, the frequency, et cetera, based on nurse-patient ratio might be different. And then where in their process does it best fit? And so you're right. You have to look at each of the units that you're going to apply it to and understand what might work, what might not. The tween is a little bit, but it's not as much as you would think. So like when we did Class C and CAUTI prevention and rolled it from the ICUs to everywhere else, it really wasn't tweaked that much. The only area that was different was, for example, in insertion, having someone in the room during the line insertion. Well, on the floor, that's not going to happen. The nurse can't be in the room. So what are you going to do different? But still important to have someone in the room doing that checklist. So that's an example of what I mean, that you don't want to move away from what the evidence tells you. You might have to get a different person to do it, or do it a little bit differently. Does that make sense?
Yeah, actually, I identify with that perfectly, because we actually just had to change some frequencies, and they weren't huge changes. It's just we could probably do it Q4 in the ICU, and then we did it Q6 on certain floors, and the Q8 was the minimum, and that was the best practice was Q8. We just went above best practice for the other two floors, and then stayed with best practice on like the med surg and the rehab floor. So we definitely had a lot of tweaking and different things working with IT. But as we were rolling out, the expectations that started with, we just had to be able to adapt to each floor. So it took a little bit of change on our part to be able to say, okay, let's look at each one and make the best decision and where it works in, as you said, that collective mindfulness.
And thank you for sharing, David, and I commend you guys in doing that, because it's going to stick. It's going to become a sustainable change because you did that.
Right, because we built it into IT, everything, so the task fires, everything goes exactly. But I will tell you, it took a lot longer than anticipated because of the resistance to the Q4. So then we had to sit with each one and kind of go through it and come up with reasonable guidelines.
And because you did that, as opposed to just saying, well, this is what it's going to be, it wouldn't have worked, right? Mm-hmm. But you identified it and you discussed, and you didn't go away from the standard, but you were able to tweak it within the recommended standard but set the expectation reasonable to their process. So
it sounds like that involves some engagement of those different stakeholders within your hospital. So, any other questions? We are at the top of the hour, so I know a lot of people are going to need to go off to other activities, but any other questions while we have Pat with us anyone would like to ask? All right. Well, thank you again, Pat. That was an outstanding presentation, and again, very timely to all the activities that many of our hospitals are working on right now. So we want to just thank you again. And thank you, everyone, for joining us. So if you wouldn't mind, please complete the webinar evaluation as you exit the webinar, and we will all be talking with you next month. So thank you again, everyone. The meeting is now adjourned.
Thank you, everyone.